Hi, everyone. I see that the numbers of incoming participants is starting to slow down a bit. So I think we'll get started so that we make the best use of our time. Hi, everyone. My name is Max Smith. I'm an assistant professor in the Faculty of Health Sciences and Department of Philosophy at Western University in London, Ontario, Canada. And it's my pleasure to welcome everyone to the first Epidemic Ethics seminar of 2021. Today, it's my privilege to be chairing the seminar on mandates and privileges for COVID-19 vaccination. As we know, vaccines are one of the most effective tools for protecting people against COVID-19, and consequently, with COVID-19 vaccination underway or on the horizon in many parts of the world, some are contemplating whether COVID-19 vaccination should be made mandatory as a means of increasing vaccination rates and achieving public health goals? And if so, under what conditions, for whom, and in what contexts? Because when we talk about mandatory vaccination, we're usually not talking about forcing people to get vaccinated, but rather talking about providing restrictions or conditions for those who do not get vaccinated, such as whether unvaccinated people should be permitted to attend school or work in healthcare facilities. We've decided in this seminar to tackle the issue of mandatory vaccination and special privileges together in one seminar. And so to help us think through these questions, we're really honored to be joined by three esteemed panelists, including Professor Effie Viana from the Health Ethics and Policy Lab at ETH Zurich in Switzerland. Professor Viana is involved in the World Health Organization's work on smart vaccination cards and is on one of their working groups. We're also honored to be joined by Sir Professor Jonathan Montgomery from University College London in the UK. Professor Montgomery recently collaborated with the Ada Lovelace Institute to explore the evidence, risks, and benefits of digital vaccine and COVID status certification schemes, and he chaired their report. And finally, we're pleased to be joined by Dr. Maya Peled-Raz from the University of Haifa in Israel. Dr. Peled-Raz will bring a perspective from Israel on the country's Green Badge plan to reopen services to those fully inoculated. Dr. Peled-Raz was recently quoted in a fascinating piece in the New York Times on vaccine privilege. So each of our panelists will give short introductory remarks on this topic, around 5 minutes each, which will then be followed by a panel discussion. We certainly welcome your questions to be addressed during the panel discussion, and we did receive a number of questions in advance that we will be tackling. You'll note that there's both a chat function and a Q&A function in Zoom. The chat function can be used for attendees to say hello, and I've seen some have done so already, so thank you for that, as well as to address any technical issues you might be having. But questions should be directed to the Q&A function. You're invited to like questions or upvote those questions that you see in the Q&A, which will help to prioritize them for our panel discussion. Finally, I'll note that the seminar is being recorded and will be available on the Epidemic Ethics website later this week. So without further ado, I'll invite Professor Viana to provide her introductory remarks. Professor Viana, over to you.
Thank you. Thank you very much. Hello, everyone, and thank you for the introduction, Max, and for the invitation. I do contribute to the WHO's working group on the smart vaccination certificate, as you mentioned, Max, but I'm also in my own scholarship, I've been thinking quite a bit about vaccination privileges and specifically in the particular use for international travel. I'm very happy that the topic of this workshop is the one that we have today, partly because in my work on international travel and vaccination certification, a frequent argument that I've been hearing is, well, there is precedent, we've done this before, we have the yellow fever vaccine certificate, it worked well, and therefore we can seamlessly transition into requiring the certification for a COVID vaccine without, further thinking. And I do think that the particulars of COVID-19, of the vaccine, of the scale of the pandemic, and many other reasons, actually should force us to think quite carefully and do our ethical analysis in a distinct and separate way. So part of this thing, in the context of the thinking, I'm quite happy that we can discuss this today. My starting point is that whenever we're going to resort to state coercion in order to pursue a public health And I think we really need to be extremely careful. Following public health principles, this seems to be something that we ought to do after we really tried out all other alternatives. And when we have serious justification that by introducing such a measure, state coercion for particular, in this case, vaccination, then we have a fairly good reason for the outcome that will result from such an intervention. So that's where I'm starting off, my kind of thinking here. And then I have a couple of points to kick us off in this discussion. One is context. I think whether we mandate vaccines, and by mandate, I tend to think of this not as forcing vaccines into people, but rather creating privileges around for the vaccinated that make it also indirectly mandatory. That one criterion of context for me is access to vaccines. And if we look at the situation we have today, most countries still face vaccine scarcity and rollout obstacles. We're having this problem in high-income countries and in low-income countries. I know we have some exceptions, and we'll hear from Israel later, but most countries are still dealing with the issue of access. It seems to be rather odd that we'll be mandating something that we cannot, even if we want to, have. Another consideration that I would kind of put under context as well is the fact that we are building public confidence to the vaccine. Despite the amazing efficacy data that we have, the increasing data about effectiveness, we're still in the process of building confidence in what the vaccine can do for us. Now, again, we want this confidence to happen in an unprecedented scale and in a new kind of speed. Last week, in several European countries, we saw that one particular vaccine was suspended from its use for concerns about side effects, severe adverse events. And again, the vaccine and those effects are under consideration. That's obviously an important thing that has to be communicated to people. But at the same time, I think we need to be mindful of the fact that this process of trying to understand, is the vaccine safe, for whom, side effects, etc., that these are in the public discourse and debate, again, are part of building confidence in the vaccines. And therefore, during this phase of confidence building, mandating something seems to me that might actually backfire instead of really making us have the effect that we want to have. My other point is about the time dimension. Now, there is a sense in which we have a time period in the pandemic. So we're at the point right now that we don't have enough vaccines for even all those people who want them. We hear about vaccine tourism rather as well in many places because of the scarcity issues. So we have a few people who have access to a vaccine. We are thinking of giving those people privileges. We have a lot of people who don't have the vaccine and therefore they won't have those privileges. But in theory, if we do increase access, and the vaccine is widely available, we have a lot of people having this vaccine, we're in our trajectory for herd immunity and for the situation we imagine. So I'm thinking this mandatory approach, for which period of time in the pandemic actually is useful, and what would it achieve at a different point? And is this our thinking adjusted to the phases of the pandemic, or we're just thinking of it at the moment without a broader plan? Now, the issue that worries me when we have the privileges for the period where some people have vaccines and most people don't have vaccines is, of course, the concern about existing inequities and structural injustices that are reflected in certain regions in who gets the vaccine. And so again, segregating privileges around people who are privileged and having those who are not privileged again falling behind, that again could create a problem that I think could cause two kinds of harms. First, to the individuals who will be on the wrong end of this equation, but also in the general public's trust to how public health measures are going to improve the well-being of our societies. So I'm not suggesting here that we should level down, and if somebody is not at risk of transmitting disease, should have her freedoms restricted the way we're doing it right now, for example. But I'm just mindful of what kinds of alternatives we have to put in place for the unvaccinated in the different scenarios of the pandemic. And my last point is this. I think I've done my 5 minutes. I'm a little concerned sometimes about jumping into more drastic policy choices in policy to perhaps also compensate for, as we've seen in this pandemic, multiple non-evidence-based policy choices that did not bring about the outcome that we would have all wanted. And so again, I'm worried a little bit if we have an intervention, for example, that we think we just have to very quickly use at the cost of coercion and other risks, whether we're kind of glossing over as states other obligations, for example, safe working environments that should have been in place in order to prevent harms that we've seen in healthcare personnel. So these are some of my thoughts in trying myself to figure out how we should go about it. But I'm increasingly concerned about the one thing, which is how we are trying to jump into policy option in a rather hasty manner. And I guess this panel and some of my own work is about holding back a little bit and think more carefully about what it means to make those kinds of choices. So I'll stop here, Max. Thank you.
Excellent. Thanks so much for that, Effie. Lots of really interesting stuff to chew on there in our Q&A. I particularly like the last point you've raised around seeing mandatory vaccination as perhaps a panacea, something that we can do. It's rather straightforward. It's a blunt instrument without really attending to some of those more structural issues that we might actually want to get the sort of vaccine uptake and reach the public health goals that we actually want to achieve. Really interesting stuff. So thank you for that, Effie. Next, I'll invite Professor Montgomery to give his remarks. Professor Montgomery, over to you.
Thanks very much. And I guess at summary, I'm going to end up with a similar observation that Effie made about mandatory vaccination with certification and passports, that it seems a bit of a distraction at this stage, given what we know and what we're dealing with. But before then, I'd like to give a bit of a summary of where we are in the United Kingdom. And we are a country who is not doing as well as Israel, but is moving through its vaccination program reasonably fast. And so this is quite a live issue in relation to certification, and perhaps less live an issue in relation to compulsion. So our history in the United Kingdom with compulsion is generally that it's not worked very well, but our history with voluntary vaccination uptake is pretty good. We've kept that in our legislation. So compulsory vaccination is actually excluded from our COVID response. And what we have is a balance between a big communication campaign to encourage people to take up the vaccination and a significant degree of persuasion being exerted in relation to health and social care staff, which are identified as an area where a high uptake of vaccination is expected by policy. We have some context for that in relation to hepatitis, we have a strong expectation that frontline health and social care staff are vaccinated and are not expected to work in exposed areas unless they are. We have a rather different approach in relation to influenza, where we encourage vaccination uptake, but we don't make deployment dependent upon it. So what we're currently discussing is essentially the professional obligations to be vaccinated if you are working in an environment where the people you're looking after might be exposed to risk. And we're pushing that on the assumption that vaccinated staff are less likely to carry and pass on the virus, but there's a considerable amount of scientific uncertainty about the degree of that at present, which perhaps we can come back to in discussions. What we have been focused on is not so much patient protection, but staff protection. We've had widespread risk assessment in our health and social care services, and particularly in health, we've tended to move staff at risk away from frontline exposure. And vaccination is sometimes resisted by people who don't want to go back into those areas, and sometimes welcomed as a chance to get back to the work that they would like to do. So our current position in relation to compulsion is that it's not being proposed, at least not by government. It's being considered by government in relation to health and social care staff. But what we're seeing is a significant private sector discussion about whether they would require staff to be immunized before they allow them to work. And in one very high profile case, we have a particular firm of plumbers who's suggested that they will not allow anyone to work in their firm unless they have had a vaccination. That feels like it's being proposed essentially as a market opportunity to try and pitch one group of employers as safer to use than others, or one industry safer to use than others. And that raises significant questions about whether the key concerns on compulsion sit with government compulsions against citizens, or whether it's in the private market, and the government response to that would need to be an anti-discrimination response to outlaw discrimination on the basis of vaccine status. So that's the first sort of area of comment around compulsion. I'd like to say something about the trust issue. In the UK, we identify that information is important, but trust is actually the key to take up. Like many other places, we have a shadow of distrust from certain communities. So the response has been to work with community communicators, trusted communicators in the communities that are hesitant, inform them as opposed to direct communication with members of the communities. There is a key issue of trustworthiness in regulation. Have we managed to speed through our approvals without cutting corners, and of course post-deployment monitoring? But what we've found is that hesitancy amongst those groups who are disadvantaged in taking up the vaccine is reducing as the discussion happens within those groups, as opposed to the state imposing them. And finally, the discussion of certification, or in the language the United Kingdom is using, passporting. The government has announced it will review this in the UK. It seems to be separating international travel from domestic approvals. I think in relation to the scrutiny like FV, I'm not convinced that yellow fever is a very good analogy. Essentially, yellow fever would take away from governments the ability to have border controls, which seems an odd thing to do in relation to a virus that mutates. Domestically, we're talking about restaurants, entertainment venues, sports venues, thinking about using certification. But fundamentally, it seems to me that the key issues here are much more to do with pragmatism than they are to do with ethics. Not that there aren't ethical issues, but certification, passporting doesn't seem to be an answer to a relevant question if we're thinking about reopening our economies over the next few months. Because even with the UK's vaccine programme, we won't have anybody eligible for being passported until the end of the summer, by which time we'll have had to have found other ways of dealing with things, safe practices at work and support. So our fundamental position, on the back of discussions in our moral and ethical advisory group within our government Department of Health and Social Care, is that we should be concerned about equality impact assessments. Access is therefore the key. And certification of passports seem to be something of a distraction at this point in time, especially given the uncertainty of science about how long any protection from a vaccine would last, and in particular in relation to whether it reduces the risks that individuals who are vaccinated present to others. You don't need certification to be able to assess the risk to yourself. You know whether you've been vaccinated or not, and it may not be of much use in identifying whether the person next to you presents you a risk until we know more about the science. So those are my introductory remarks, and we have been borrowing from what we know is going on in Israel, so I'm looking forward to hearing more about that. Thank you.
Excellent. Thanks very much, Jonathan, for those remarks. I think the point about mandatory vaccination privileges being a distraction at this point in time, also looking at the temporal element, which Effie raised, when would this be justifiable, or would it make sense to do this, is an interesting question that I think is a thread that we're sort of seeing run through this conversation. So thank you for that, Jonathan. I'll now invite Dr. Peled-Raz to give her introductory remarks. Over to you.
Thanks, Max. So I'm sitting here and I'm smiling because I was saying exactly what Jonathan just said. Probably about 2 months ago, I came out in a paper and I claimed that this whole discussion about mandating vaccines and using green badges, as we call them, or green passports, is a destruction and probably just causing harm more than it's doing good. And we are here 2 months later, and it's actually been done in Israel. And I think that one of my first comments in this regard should be that we need to be very flexible and adaptable when we are dealing with COVID-19. I think this disease has surprised many of us, if not all of us. It turned out to be one of the most unexpected event, not only in its emergence, but only in the way that it developed. And things have been changing rapidly within the discussion from 1 week to another. And you might find yourself in the UK or in other countries in 2 months' time saying, wow, we did not think this would, evolve this way so fast. And we actually are in a place where we need to discuss those things. Now, when I'm saying discussing those things, I think that we can all agree that mandatory vaccines are off the table for the general population. I can say that right now, there is a discussion, not a heightened one, but it's, flowing underneath the surface regarding schools and education in general, in terms of what we can expect from teachers and kindergarten teachers and so on. But when we're looking at the general population, this is not really an issue, a relevant discussion. But it turned out that talking about the green badge is a relevant discussion. I do want to reframe it in a way. I think it's been discussed a lot in terms of an incentive. But the main issue and the main goal of the green badge is not to serve as an incentive. That might be a very nice side effect. But the main goal of using a green badge is to stop limiting the rights to movement, to occupation, to entrance to places, and so on and so forth. Stop infringing on those rights when we are talking about people who are now vaccinated, fully vaccinated, and are no longer at significant risk to themselves, and probably are at a much lower, posing a much lower risk to others. And data is accumulating on this regard as we speak. We did not know a lot about that 2 months ago. We do not know quite a lot, definitely not everything, but quite a lot about it today, relying on the data, amongst other things coming out of Israel. So we need to ask ourselves, is it justified? Is it ethical and legal to continue telling people you cannot move, you cannot operate your business, you cannot enter movie places or whatever, although you are no longer a health risk, at least for a while, until we figure out what, for how long vaccines hold. And I do want to touch on a few things. Just like a few days ago, a nice article came out in the Lancet. So I'll share a screen for like a second. The authors there, who are a group from the UK and Australia, listed a list of ethical objections which they discarded. Okay, so they basically thought that those were not good enough to serve as an objection to using a form of a green badge. Okay, and I do want to just generally say a few things about each one of them, and then to focus on one really small issue, or not so small, but I'll make it small. So there are concerns regarding privacy, and I think that those should be handled, but they should not be considered as an issue that would prevent use the use of green badges. So you need to make sure that, the population's medical information would be guarded in an appropriate way. And that needs to be worked into the system, but not to serve as something that would, disallow it continuing to be developed. Marginalized groups and discrimination, that's a real issue here. And we do know, and this is, I think, a slide that really proves it. So what you see here this is data from The Guardian from yesterday. So this is the UK yesterday, and this is Israel in January. And we see the same thing. We see areas where you have high prevalence of disease of COVID-19, and those exact same areas have very low prevalence of vaccine intake. And it's the same here, okay, in Israel. And there's a direct line between your social economic strata and whether you be sick and whether you be vaccinated. I'm happy to say that we are now 2.5 months later, and this is no longer an issue, generally put, no longer an issue in Israel. We do have certain specific communities that we are not doing a good enough job to vaccinate, and I'm talking about migrants communities and the Palestinian workers and the general Palestinian population, which we have not done a good enough job, if at all, in vaccinating, and this should be addressed. But this is no longer an issue, and I'm expecting, and I know that you find it really hard to see it now, but I'm again expecting that in 3 months' time, you'll be in another place in this regard. And the way to be in another place and to close those gaps, I think, again, should be really hard, working hard on access, but also on working on solidarity. And I because I'm running out of time, I will not be able to run through all of this, but undermining solidarity has been one of the concerns that were brought up there and kind of chucked away by the authors, basically saying there's no evidence of that. We know you're saying it, but there's no real evidence of harm to solidarity and to solidarity being an issue, an actual issue in vaccine intake. And I want to show you this graph. This is from a lovely article coming out of Israel from 2019. And what they checked is the correlation between Gini index, which is the inequality index, okay, inside of a specific settlement, okay, city or town or whatever, and how it impacts vaccine compliance and intake. And this is lovely because what you can see here is that was actually checked for OPV, which is oral polio vaccine. We had a polio outbreak in 2013, which we had to handle really, really fast in Israel. And we offered everybody oral polio vaccine on top of their standard vaccine for the children immunization program. And it was not mandatory in any way, although we knew this had to happen because otherwise we'll actually have polio. And they went afterwards and checked the vaccine uptake, compared it to the Gini index. And what you see here is that although generally found higher socioeconomic stratas tended not to partake in the vaccine endeavor. Okay, so if you were rich, you basically tended not to get vaccinated. Okay, and if you were poor, you tended to, which is the opposite to what's going on right now with COVID. But the point is not that. The point is the Gini impact. And what you see here is that when the Gini index is small, so disparities are small, and in that same space, you have people from the same strata, generally said, okay? So most of the people are, you know, poor, or most of the people are rich, or most of the people are in the middle, and you don't have huge disparities inside of that town. Uptake was higher, okay? So they analyzed it, and one of their major assumptions, and they actually interviewed people later on in another article, which kind of backed it up, this assumption, is that solidarity matters. So when you feel that you are part of a group that's like you, and that you are treated equally, and that this is a communal strife, that you are all working for something together, you tend to pitch in. And I think that we really need to consider this solidarity problem and figure out whether it would do more harm than good. And the answer may not be similar to all countries. And it really depends on how fast the rollout can be and the gap closing can be. The longer it would take, solidarity would, I think, matter more. Thank you.
Thank you, Maya, for really interesting remarks, and to provide a little bit of data there to give us a sense of how this is really playing out. And it strikes me that you kind of made an argument for mandating solidarity, if only we could do that. So thank you to Maya and Effie and Jonathan for your remarks. Really interesting, lots to chew on, as I said. One comment that I think I'd like to jump on, and I'm seeing a lot of questions that kind of surround this issue. We're seeing that mandatory vaccination might bump up against or rub up against issues of equity. We also see that mandatory vaccination might rub up against issues of trust. And my question is, these are ethical concerns that are being raised. Is mandatory vaccination antithetical to the enhancement of public trust or to the promotion of equity? Can we do these two things at the same time? Is there a way to do that in your view? Or if we pick, if we make the choice to follow a mandate, does that mean that we will simply have to live with more inequities or less trust? Curious, any panelists might have thoughts about that.
I've volunteered to go first. Effie was a bit slow behind. So I think I'm inclined to the view that compulsion is antithetical to trust, and that the more you require people to do things, the more they wonder why you're requiring to do them, and therefore the more suspicious there are. I don't think it's necessarily antithetical to equity, because it might be one of the techniques we could use to distribute resources more evenly and to encourage take-up from people who are hesitant. So I do think we shouldn't underestimate the extent to which those elements of inequity, though, are driven by very logistical, low-level problems. So, for example, in the UK, we've been having a discussion about vaccine prioritization, and there's a strong argument being put forward in a number of places that we should prioritize communities who've been adversely affected by COVID, particularly those from ethnic groups. And that's very difficult for us to do because the data that we hold in our health system about ethnicity is not very reliable. So it's not so much that we don't recognize that that's a valid consideration of prioritizing the most affected, is that actually delivering it is more difficult. So it's probably more efficient for us to prioritize the supply of vaccines to geographical areas which have high numbers of people from particular ethnic groups than it is to have a debate about whether it's more important to prioritize them first. And then you get the problem, which I think Maya's slide from The Guardian shows very nicely, is that the geographic areas we use have inequalities within them. So you send it to an area of London, which you're trying to prioritize, and the people who take it up are the ones that you're not trying to get to. But those are very pragmatic problems that possibly mandation could overcome. So I think absolutely undermines trust, but might be a tool in relation to equity in some circumstances.
Maya, please go ahead.
Oh, yeah, I was actually pointing like a student. Two comments on that. So in regards to trust, I think that we cannot, and I don't want to use the word mandate because that's not the issue, but use, tools that would differentiate between those who are vaccinated and those who are not, or certain incentives and so on. In regards to trust, we cannot use those tools without genuinely acting to promote trust. And I think that it requires good communication. It requires good faith, which we don't always see. And I think we need to, in advance, recognize the difficulties of using that and telling those communities, we know that you are now, having the lower hand. Okay, you are suffering because of this, or you are disadvantaged because of this decision. But one, we have to allow the economy to reignite. It would help you at the end. And we are promising you that we would do whatever we can to favor you. And this brings me to equality, to favor you, when we can, even if that would actually harm equality. Okay, so I'll just give you it's a dumb example, but I think that's one of the things that really helped in Israel in this regard. And that again brings us back to the issue of being flexible, which I know is not always easy. So for example, throwing away vaccines because nobody came in to be vaccinated from the priority groups is wrong. Okay, I'm saying this categorically. And what we did is that the minute vaccines were left, notifications went out to the local community saying, listen up, guys, we have 5,000 vaccines left if you come in the next 3 hours. Okay, and we were prepared to actually deliver those vaccines even after hours. And we said, so if we are vaccinating over 60s right now, but we have 5,000 vaccines or 1,000 vaccines left, we'll vaccinate everybody over 40. So we're still, prioritizing, but we're way more flexible in prioritizing, and we're doing it locally. So this is for your, neighborhood. We're publicizing it to you. Come in. One of the things that this did is it grabbed the compliance. Those people who really want to be vaccinated, but now are still not, prioritized, and it allowed them to come in, be vaccinated, tip up the vaccine rates in that specific community, and also serve as an example to everybody else. Because again, seeing other people like you being vaccinated is one of the things that most promotes, trust in the vaccine and solidarity. So be more flexible and try to find ways to, prioritize those populations, even though it's actually, getting you away from the strict prioritization scheme. But it's for them, it's for those who are least well. So I think ethically it's justified, to tip the scales for their benefit.
Please go ahead, Effie.
Right, thanks. So I tend to agree with Jonathan that mandating something here, I don't think it will go a long way with trust. And it will depend, of course, in the context, cultures, past experience and everything else. But if I'm thinking to myself, why would somebody, if we have a trusting relationship, why would somebody force me into doing something indirectly? Again, not the compulsory maybe version, but indirectly forcing me into something. It doesn't compute in my view as well. Now, when it comes to equity, again, my question is that why do we have to get and again, depends on context and where we are, but why do we have to get to more equity via something that's mandated? And the question there for me would be, what else is happening with the aim of reducing inequities other than mandating something because it is for their good? And as Maya said, because it's for them. I won't be so convinced that it is for me if I'm always at the recipient end of not having the good thing for me. And if traditionally I had years and years of not receiving the good stuff, I would be worried that now you show up and tell me you're forcing me because it's good for me. I think I would probably not be so easily convinced. So when I was thinking of closing the equity gap through mandates, I think we need to be seeing in parallel a lot of other action that leads towards reducing equities, and not just for the short term, because a lot of the problems we see here at the moment of COVID is long-standing inequities that they've built up over the years. And again, solving a problem right now, it is a priority, of course, because we have people dying and we need to solve this pandemic and exit from it. But at the same time, I think we need to show that what we're doing are things that have sustainability in terms of reducing inequities for more than just the minute right now. So what I want to see when we claim that a mandate will reduce inequities because in the short term will give more vaccines to so many people, I think I want to see the parallel action that convinces me of the true and of the honesty of the claim, and this is what sometimes I'm missing. Of course, you flex political muscle when you say I'm doing this and I'm going to do it for the good of the world and all of that. But then I want to see what's more in there. And perhaps one more in the trust. One of the issues that I see with the trust, and again, mandating something for me, it's not really going to work so well with trust, is the extent to which we all say, well, we have to be better communicators or we have to explain to people. But I think one thing we're not doing is listening to people. It seems to me that a lot of public health communication is one-way traffic. We're going to tell you what's the right thing to do and you got to do it. Well, we need to listen and understand also why people are not doing the things that they ought to do if they were good public health citizens. And there again, perhaps COVID will give us an opportunity to be more innovative. And I agree with being more flexible, but I think we need to be a little bit more, even under the pressure of time and wanting to fix something very quickly, a bit more reflexive in some of those issues.
Thanks, Effie. I'd like to pick up briefly, if I could, on the unintended consequences of having something like vaccination certificates or passports, and what that might do in our society with respect to the degree to which those that are beneficiaries of those privileges, whether they will still follow other sorts of measures or not. So Jonathan, I'm wondering if you'd like to speak to that and the perhaps trying to relate this back to this idea of solidarity and how do we really get at this from the perspective of solidarity?
So thank you. So, I mean, one of the things that we've been discussing in the groups I'm part of in the United Kingdom is how do we interpret the behaviours we're seeing from people who've been vaccinated, which don't really relate to the scientific advice they're given. So you're seeing people who've had a vaccine immediately feeling safer, reducing the compliance with mask wearing and social distancing, despite all the evidence, information being given to them about it takes you a number of weeks to come in, you don't get your full protection to a second vaccine. And I think one of the worries that we have around certification passporting is that it puts all the weight on one element of our response, so that it could turn out to be counterproductive. If you think I've got my piece of paper or my app that enables me to do something, that's the only thing that matters. And there's linked with that a sense of individual isolation, that somehow we can address the COVID issues by each individual being safer. Whereas I think anyone looking at it from a public health perspective would think that actually we can only address these things by acting collectively. So I think the piece that my friends and colleagues from Oxford that Maya showed in the Lancet, I mean, it downplays the lack of evidence, because there's a lot of evidence we have which is germane to this issue, which should give us cause for concern. And I suppose my fundamental anxiety on the sort of logical side of certificating and passporting is that it takes something which is full of uncertainties, like the immune response of people who get vaccinated, the duration for which any protection lasts, the relevance of that degree of immunity or reduced risk of transmission to the circumstances in which I have been, who have I been associated with, have I been undertaking risky activities, how long since I've been quarantining. And by picking one indicator of this, you suddenly create a fetish of a piece of paper or an app, which then undermines our ability to think holistically about the approach. And I agree with Effie. I think that we'd probably get sucked into, I'm not sure how this metaphor translates, a rabbit hole, a tunnel, if we put all our weight on COVID ethics and we lose sight of our sense of what a good society looks like. So I think one of the challenges for epidemic ethics is to ask itself the extent to which it's like biomedical ethics and rooted in relationships between healthcare providers and citizens, and to what extent it's actually a product of political theory and what is the type of society we want to live in. So when I look at the, say, statement out of the European Group of Ethics on COVID, it was all about social solidarity. When I look at material that comes out of the United States of America, it's all about individual rights. Now, they respect different political traditions as much as they respect differences around COVID ethics. So it seems to me that the further back we step and get a broader perspective of what's at stake, the more likely we are to address both those issues about equity and about trust.
Thanks for those comments, Jonathan. And I'd like to pick up, if I may, on the questions of evidence, because we're seeing a lot of questions both before this seminar as well as during it about the degree of evidence that we have and whether they sort of meet a threshold to justify either mandates or having special privileges for these vaccines. And one of the questions that I think emerges in this context is, the idea that, do we need to wait for full certainty, or at least some threshold of certainty, to warrant mandates or warrant special privileges? Or on the other hand, might we say, even though we don't have full evidence about duration of protection, or we don't have full evidence about whether the authorized vaccines are effective in preventing transmission, might these special privileges or mandates at least constitute a form of harm reduction, that they'll go some way in preventing disease or preventing some sort of socioeconomic deprivation? Does that argument hold any water to you? Do you think that that's a specious argument? What are your thoughts about that?
I mean, I think it's an unavoidable argument in this pandemic, because we've had to make so many judgments without really knowing what the evidence shows. I mean, I'm trained as a lawyer, so I'm used to this. The lawyers basically have to convert uncertainties into something certain, and then they pretend they're certain, and then they work from there. So in my system, if something is more likely than not, it then becomes treatable as if it's the case. What I think has been very apparent to me in COVID ethics is the way in which we've had to think much more about making provisional conditional decision. So I was involved in not just work around COVID certification, but also around contact tracing apps. And the way in which we've had to approach that is, if it does this, then this seems to follow. And if it does that, then that seems to follow, because you're having to give the advice as the evidence is being gathered. And you don't want to look stupid because you've said something shouldn't happen, and then immediately the piece of evidence you said was lacking emerges. So it seems to me, in relation to certification, it's highly plausible that we will reach a stage where there is evidence that being vaccinated reduces the risk of carrying the virus and transmitting it. But what's not really known is how strong that evidence is. So in one piece of discussion I was involved in, we try to ask ourselves, what would the position be if the evidence of that was high, the competence was high? What would it be if it was medium? And what would it be if it was low? And try and give some conditional advice to say, these things would lead to significant differential treatment, and we should only do those if we have high confidence in the evidence, whereas these other things would not raise such equity concerns, and we might deal with a lower certainty, and they're broadly dependent on how central the restrictions are to our life. So if you want to stop people going shopping, then you need a high degree of confidence. If you're dealing with something that is highly discretionary, then you might allow it with a lower degree. So sort of, can we build in some conditionality to our thinking?
Great, thanks, Jonathan. Maya, did you want to weigh in on this one?
Yeah, although I completely forgot what you asked, but I would like to say that I think that looking at the issue of however you call it, a green badge or this piece of paper, as one-dimensional would probably be wrong, because this can never be the one tool to be employed. You have to build a system into which it would fit in a way that would allow for everybody to participate as much as possible, and people would be treated as less equal as possible, and so on and so forth. So, for example, for many things, the green badge would not be relevant at all. And this, relates to one of the last things that Jonathan said, that for certain things, you cannot mandate anything, okay? So people need to buy food. People need to get into the pharmacy. People have to do certain things that, the green badge would not limit them in any way, and will just allow everybody to do that. At the moment where we feel secure enough to start, alleviating those restrictions. For other things, we may say, okay, green badge is one way to participate, but we do accommodate other things, okay? So for example, we are all focusing on vaccines, but COVID tests, the access and availability of COVID tests is also a really important issue. And if we allow people to be tested regularly, that could be a really efficient way to allow them to participate, even though they were not vaccinated yet. So for certain things, they can enter with, being tested. And for other things, which are pure, luxuries, there we might have the difference, and we need to figure out whether that's okay with us. But again, I want to say something which is just empirical, and I wouldn't be able to think about that like 2 months ago, but it's a fact right now in Israel. There's a tendency to things like that to just don't happen. And again, there will be, exceptions, but I'll give an example. Okay, so right now, if you have a green badge, you can enter movie theaters. And there's a really small window of opportunity for green badge to be relevant, because you need enough people to be vaccinated, but not enough people that you'll have to just chuck everything away and just open everything up. Okay, so it's a really small, and in Israel it was a tiny window. Okay, I think by next month it would not be relevant, or maybe like, the minute we can vaccinate children, it will be over, this window of opportunity. And for other places it might be a bit longer, but it's still a small window of opportunity. So just for the example of movie theaters, you are allowed to operate movie theaters right now in Israel only for vaccinated people, because it's a luxury. You can watch movies, in your own living room. But most movie theaters did not open because movie theaters, base their profits on popcorn and children. And both of them are just not relevant, okay? Because you can't eat in a closed place, and children are not vaccinated yet. So, okay, so there are like a really few movie theaters that are actually operating right now. And
Mayor, I think that's really important. So there's a big debate in the UK at the moment about summer holidays. But if you look at the timetable for vaccination, we're not going to have nearly enough people with 2 vaccinations eligible for a passport in time for the school holidays. There are lots of discussion about a window that the following year, everybody will have had the chance to be vaccinated, so you wouldn't need it. But that window of opportunity globally might be a rolling window, mightn't it? So it might be very short in any individual country, but it might be still something valuable across the world, particularly as we know how important tourism is for some economies, so that we don't want to increase the disadvantage of those economies, particularly in places which might have relatively low incidence because of high incidence elsewhere.
In that, in this regard, we can move back to to the second option, okay, of you can't, do a green badge without, when possible, give other options. It cannot be a sole solution in any case.
Thanks, Maya and Jonathan. So Effie, I want to give you a chance to weigh in before we get to the top of the hour here. Over to you, Effie.
Sure. I'll go back to your question. Your question was whether we need to wait for the evidence in order, or perfect evidence or sufficient evidence in order to implement things. And I would say that one thing we saw during the pandemic is that we actually did not wait for the perfect evidence, and we had no time for it, and it would have been the ethically actually wise thing to do. We're trying to look even for alternative types of evidence that would meet certain criteria so we can move on and act and save lives. So I think we crossed that line. We are not after the perfect evidence. We are after sufficient evidence here in terms of what we can use. One thing that I'm not sure we did extremely well was to be agile and respond quickly to the changing evidence. And I think that's maybe something we need to look at and see how we can operationalize it. I think until now, we did have the luxury of time. We collected the evidence, we sat on evidence, we consulted and deliberated, and now we have to have systems that very quickly respond to continuously changing knowledge and evidence. And that would be very, very helpful. Quick example, for a whole year, we have a travel ban between the United States and Schengen countries in Europe, a whole year. So much has changed during this time. The travel ban, and that's not travel controls, that's not border controls, quarantines, tests, all of this. It is a ban that we haven't seen ever before, I think, at least maybe for some countries, but not continent to continent. And still, a year later, we're on it. Now, how reflexive and how have we been on that? How responsive to changing evidence, to new technologies, or to rapid tests, or whatever, all of these things that change. So I think we have gone along with imperfect evidence, but that means we need to be more agile in incorporating this in our practice. And I agree with what Maya said, and I think maybe Jonathan as well, that we need to be thinking of the alternative routes, right? I do believe these certificates is a distraction. Even 2 months later, I think they're still a distraction because the window is so short. But what about the alternative options we have? And that actually would be quite helpful in not creating big inequities or differences between the vaccinated. They can get their liberties, but the unvaccinated can have a way to at least, exercise their fundamental rights or pursue their interests. So that would be my thought on that.
Thanks, Effie. And I hate to end the conversation, but I think that's a great point to leave this on. Of course, we could spend multiple more hours, I'm sure, thinking about this. But thank you all for a very productive and stimulating discussion. This was really great and clearly has addressed some issues that obviously we'll be grappling with over the next few weeks and months. I'd like to particularly thank Effie, Jonathan, and Maya for your contributions today, for everyone for their questions, and to Epidemic Ethics for hosting the seminar. We encourage everyone to check out the Epidemic Ethics website for announcements of future seminars and workshop style events that we'll be introducing later this year. And you will be able to see the recording of this event on that website shortly. So thank you everyone again for your contributions, and we look forward to seeing you at future seminars. Thanks very much.